All right, so I think we'll get started. Thanks everyone for joining us. My name is Melody Clark. I'm the Senior Marketing Manager for Ideal Option, and I'll be kind of moderating today's webinar. We're lucky to be joined by Peer Seattle and Peer Spokane to present this live webinar diving into 12 myths and misconceptions about recovery. So we'll go ahead and get started. Our presenters today will be Patty Marshall, who is the Associate Director of Peer Seattle. We also have Julie Hinkemeyer, who is the Program Manager for Peer Spokane, and Dan Harmon, who's a Program Manager for Peer Seattle. We also have Jeff Godfrey, who is one of our wonderful providers at Ideal Option. And we'll go through the myths today, and then we'll open it up for questions. And people can raise their hand or chat their questions towards the end, and I'll open it up and moderate those questions, and we can have the presenters address them. So if everyone's ready, I will hand it over to Patty to get started.
Great, thanks. So hi, I'm Patty Marshall, and I'm with Peer Seattle. I am an associate director, but I'm actually the associate director of our new Kent location that'll be opening this fall. And at Peer Seattle, we provide peer services and recovery coaching. And I'm going to let Dan explain a little bit more about what we do at Peer Seattle, because I'm fairly new. Just been there a few months, but I'm a peer and a person in long-term recovery. And I'm going to just go ahead and pass it over to Julie to do her introduction, and Dan can give you a little bit more of the history of what we do at all our peer locations.
Hi everyone, I'm Julie. I'm the program manager here at Peer Spokane. I am in medicated assisted recovery, so I believe in what we're doing today very much. And I got brought on about 5 months ago when we opened Peer Spokane, and we are a kind of a sister thing of Peer Seattle, and we do a lot of the same things as Peer Seattle. So Dan, why don't you give us some little insight about more of what we do?
Hi everyone, my name is Dan Harmon, and I am the program manager, or I am a program manager at Peer Seattle. And I've been at Peer Seattle for the last 5 years. You know, we're a great organization. We're LGBTQ focused. You know, we really focus on anyone who needs help in any kind of recovery aspect. So we do kind of the complete focus on recovery. So we really try to treat everybody as a whole person. So we do a lot of recovery coaching. A recovery coaching program has been at Peer Seattle for like the last 10 years. So we've been doing coaching for a long time. We have groups. We have 120 different groups, some peer focus, some 12-step focus. And that's what we do. We're just here. We meet people where they are, and we just go with them down the path. So it's a great organization, and growing, and it's really fun. I really enjoy it. It's been a lifesaver for me. I know it was the first place I came when I went into recovery. So.
Great. I forgot I didn't give a quick introduction about Ideal Option, so I'll go ahead and do that. Ideal Option is one of the leading addiction medicine providers of medication-assisted treatment, and we have 71 clinics in 9 states. And since the pandemic, we've also started offering video visits through our virtual clinic. And at the end, after we talk about the myths, we'll show a couple more slides, just more about Peer Seattle, Peer Spokane, Ideal Option and where you can find more information. And before we get started, I'm just going to ask all the panelists, if you're not speaking, to mute yourselves and then unmute when it's your turn to speak again. So we'll kick it off with, I'll throw it back to Jeff and have him introduce himself as well.
No worries. Thank you very, very much for allowing me to be on this show with everybody today. We at Ideal Option are such a fan of working with our community partners to get people help, to get people safe again, to get people back to a holistic method of grabbing their lives back. So Dan, Julie, and Patty, I am so honored to be with you all. We do medication-assisted treatment, and I love that the myth that you guys were addressing, that there is only one way to recovery. No way. You know, I did pain management for a long period of time, and I got into addiction medicine, substance use disorder work, and found that it had broadened my idea about how we help people. We are healers, all you guys out there. So I believe in the full boat of everything that helps people. We meet everybody where they're at. And so let's bust that myth today, that there are all sorts of different ways to get help, to get harm reduction, to see lifestyle changing. And we at Ideal Option really find that the medication-assisted treatment is a wonderful tool to combine with everybody out there. So, and they saw fit to promote me. I am a provider. I'm a nurse practitioner, and I do prescribe Suboxone and Vivitrol. And what I also, they promoted me to community outreach liaison. So I get to work with all you guys and just get a real broad method of working with patients and people. So where are we going next, Melody?
We'll start with myth number 1. So I'll throw it back to Pierre.
Hi, this is Patty again with Pure Seattle. And so the first myth that we came up with, really that seems to come up the most, is that there's only one way to do recovery. We hear this a lot, but what we know works is that people need to make their own individual choices. And so there's lots of different pathways to recovery, and recovery should be defined by an individual. And so I just kind of want to turn it through. We're going to let each one of our peers talk about each slide for just a sec. So I'm going to turn it over to Dan from here and see what his comments are, and then we'll do that way on each of these slides, and Julie will speak as well. So, so go ahead, Dan. You can give thoughts on this.
Thank you, Patty. So yeah, you know, we have found, and we do know that there are so many different paths to recovery. Everybody, what works for one person is not necessarily going to work for another person. So we really will follow that person to wherever they want to go. You know, it's not our decision on how their recovery is or how they need to do it. It is the person who is in recovery. It's all about them. We're going to support them in whatever they feel like they want to do. So I really feel strongly in that, and I've seen it work. You know, what works for somebody isn't necessarily going to work for another person. So it's really important that you let the person who is in recovery decide on what they want to do and how they want to do it. Right, Julie?
Definitely. That's why I love Pure Spokane and Pure Seattle, is because I am a medicated assisted person in treatment. I've been in recovery for 8 years with that. And so that is my choice in my recovery, and to have acceptance in that is really important to me. So I'm just grateful to be a part of Pure Spokane and Pure Seattle and to be on this today. So back to you, either Patty or Melody. I'm not sure which one.
We'll go to Jeff, actually, with myth number 2.
Yeah.
Jeff?
Remember, I got to unmute myself. All right. So what I was saying is the myth is that Suboxone replaces just one drug for another. And I get that a lot. I get the sheepish look that the patient has been going to a different group and they get vilified or that they feel that they can't talk about it. And so part of this, working with this disease, is I like to work with my patients that we're dealing with a disease, we're getting healthy, we're using all sorts of different tools, and medication-assisted treatment happens to be one tool. And you can find your own personhood, you can find your own, you know, locus of control in your heart and in your head once your body is being assisted. And so you don't have the cravings, you don't feel that the triggers don't become overarching and drive you into use again. So with this medication, you're allowing yourself that freedom and developing more control and a clarity of thought. We have found there's tons of evidence. We are an evidence-based group of clinics, and our medical directors have followed the evidence from the American Society of Addiction Medicine for a number of years now, as we've grown and see how we work together with peer support groups, with counseling groups, with lifestyle change and modification, and the medication-assisted treatment. We do know for a fact that you know, relapses after a period of time of being free from an opiate can lead to death. So we are harm reduction as well. Would anybody like to follow up on my bit of talking?
I think we'll go to myth number 3.
So myth number 3 is recovery is not for everyone. We hear this a lot. I think all of us that are in recovery have heard this, you know, that maybe some people are not able to reach recovery, or that's not a realistic goal for them. And we really have a core belief that recovery is possible for everyone and anyone. And so often that is a lot of the belief that it's not possible is due to internal and external stigma that we see, and it impacts. I know that was true for me with my own story about what I could do, or even understanding what possibilities were out there for different approaches or pathways to recovery. So I was one of the people who believed that once I decided to sort of admit that I needed behavioral health support in general, then I wasn't sure I could really work again. Not at the capacity that I had worked. So understanding that we all have our strengths and our skills, and recovery is just part of that life process for those of us that choose that pathway, then, you know, life isn't boring anymore, and it becomes really exciting to see what new things we can do. Dan or Julie, do you have some stuff you want to add? I know you do.
I do. Thanks, Patty. It surprises me when I hear people in recovery coming in and saying, you know, I was told that I can't work for 2 years, I can't date for 2 years. You know, and that is not true. Maybe at the beginning, maybe, you know, for the first 6 months, you know, and it just depends on the person. You know, working is part of recovery. You know, you need to focus on other things in life. Recovery is going to be your top priority, but getting back to work is recovery for a lot of people. Dating, I mean, dating is part of life, and you know, it's just I've always been akin to making sure that if somebody feels that is going to help them in their recovery, then I am all for it. Again, you know, we're going to meet the person where they're at and whatever they want to do. And I'm guessing, Julie, you probably have some thoughts about that as well.
I think that recovery is it's a choice, and no one can get into recovery unless they're ready for recovery. And I think that that's a lot of the stigma around it too, is people are forced or pushed into recovery by family members, friends, but it has to be up to that person to really want to jump into it and give, you know, their whole heart. But that's what I love about Pure Spokane and Pure Seattle, is we meet them where they're at. We're a harm reduction model. So if they want to come in and they're high the first time, great, you know, we'll help them through it, because we just want them in the door, you know, to get them services and get them the best help possible. And that's all I got to say.
That's great.
Can I jump in for a quick moment?
Of course.
And this is a provider taking a look at people coming in, and you're absolutely right, Julie and Dan and Patty, that it's a control piece. It's the person as they begin to start loving themselves again, and what they say. It is possible. And for me as a healthcare provider, and when I see the health and I see the eyes of somebody go, oh my gosh, I didn't think I could do that. You know, this is the longest time that I've been sober and free of the control of that darn drug. And, you know, so what I think we're doing today is really trying to eradicate stigma. I think that's the philosophy, and that's what we all are working toward. And it's so endearing when, you know, I love to hear so often people come into our office, you know, ideal option saved my life. No, you know what? We were there for you. You saved your own life. We just helped you, support you. And there's this compassionate support that recovery is for everyone when you're ready and when you pick the time.
Definitely.
Good.
All right, Jeff, do you want to go on myth number 4? You're on mute.
I'm going to remember that darn mute thing, you know, because more often than not, when I'm in the clinic and I'm talking too much, people wish they could mute me. So anyway, you can get high on Suboxone. Myth number 4. Sure, it's a partial opiate agonist. Okay, so all of the fentanyl, heroin, oxycodone, hydrocodone, morphine, Stadol, whatever is the drug, the opiate that you are getting high on, that Suboxone is a partial agonist. So remember, your mu receptor, here it is, if you have an opiate in there, right, no transmissions can affect. And that's what the limbic system is dying for. Oh man, I love this. Get me more of this. And so I will give you withdrawals if you don't give me more of this. I will make you feel like crap if you don't get me more of this. But now we've got a wonderful partial agonist, right, that blocks the mu receptor. So now the transmission can occur, but the opiate won't fit into the mu receptor. And it's as simple as that. That is how the drug was designed and how it works in the pharmacodynamics of how your body works with it. But it's dose dependent, and so it's very carefully prescribed. And there have been people who are naive to opiates who have taken Suboxone, and yeah, they can get the euphoria. They can take too much. So it rarely happens with good discussion with the individual. We're working together, and I've had patients who have gotten so much clarity of thought that when they're on, let's say they're on their dose of 20 milligrams, and that's what took them to completely allow them clarity of thought to stay away from the gram and a half of heroin that were shooting up daily, right? And then they're with us for a while, and all of a sudden they're like, hey, you know, Jeff, I don't think I need to be on 20 milligrams. And so we play with the dosage, and we look at the patient and how they're functioning and what kind of locus of control they've developed and where they're at in life and the clarity of thought. And it's like, okay, you want to try a little bit less? Let's see what happens. But isn't there a funny statement? I want to get Dan and Julie and Patty to kind of weigh in on this. There's a euphoria, a natural euphoria, of being healthy again, of being free from whatever substance it was. So that's kind of the balance. There's a more organic or natural euphoria that is through healthy lifestyle. Anybody want to weigh in on that?
I would love to. Being on medicated assisted treatment, I really like what you say, if you're on the right dose, because it's really important that happens, because I know when I first got into treatment, I wasn't quite ready. And I, manipulated and lied and wasn't on the correct dose. And then when I really got to the point where I was ready and I talked to my provider and, they got me on the right dose, 8 years later, I'm weaning now, but 8 years later, here I am, I've been clean and sober off for 8 years. I got my life back. And, like you said, we want to thank the provider and say, it's all you, thank you, but we have to put in the work ourselves. It's very important that comes along with the medication to help with those cravings and the effects of that. And so I'm just thankful I got my life back, and I'm thankful to be here. So
congratulate. You know what, Julie and Dan and Patty and anyone out there listening today, thank you so much for making me a better practitioner, because understanding and meeting you where you're at, but also you said something so wonderful, Julie, that yeah, you were manipulating, and that was part of your lifestyle before coming in there, and we have to parse that out. We have to stretch that out and find where me as the provider can work with you and listen and let you develop your control and say, all right, Jeff, you know what? I'm BSing you. All right, let's get this together. And then we match each other on our therapeutic journey. All right, I'm sorry.
That's all right. We're just trying to keep on track. So I just want to echo, I'm so thankful, Julie, that you are here as well. So congrats to all of you in recovery. So myth number 5.
Well, addiction is not a choice, right? And you can quit if you want to bad enough. People who have had experience with so many different drugs, after a while, your chemicals, your brain changes. It's not as easy as saying, you know what, he can just quit if he really wants to, which is why we see so many people fall and slip on their way. It's not easy. It's hard. It's hard. I see a lot of people, especially people who count days and stuff. They'll get to a certain point and then they'll relapse again. It's hard. It's difficult, and it takes a lot of support. It takes family. It takes your therapist, it takes your coach, it takes your sponsor, it takes somebody who can sit with you and be with you and hold space for you with no judgment. You know what? If you have a slip, you relapse, you just knock it off your shoulder. It's behind you. There's nothing you can do. You get up and you go on. So I really feel strongly that when people say, that you can quit when you want to, you can't necessarily always do that. So I guess I really feel strongly about that one. It's not a choice. Things just happen, and then it's no longer a choice. Sometimes you need, especially with alcohol, right? After a while, it's not a choice, and you can't just quit. You need help to quit. You have to go through your detox. So I'm guessing Patty or Julie, you might want to add to that.
Yeah, Rose, can we go back to the myth slide that we started on? Because I really, sobriety or abstinence being the only real choice. To number 5, yep. And it really, we want to talk about it being also very individualized, and that for everybody that maybe I tried, like in my own recovery, I tried a couple of different things before I kind of figured out what I needed in order to continue to move forward to live my best life. And you know, that started out as a very much a harm reduction model, where I just looked to see where I could find that balance, and really understanding that recovery isn't linear, and this can come from a lot of different places. So we hear this externally, we see it on Monday night movies, right? We really just try to hold that hope for folks doing peer work. We try to make sure that regardless of their choice, we can just learn from that and kind of decide what a new goal is and work forward, and just let people define recovery in any way. For me, it involves my grandkids and my horses, and lots of things like work, and just kind of understanding my relationships better. So it really isn't all about just abstinence. And that can be a real challenge. There's a lot of stigma in the community when you're kind of finding your balance in that kind of stuff. So I just wanted to bring that into the conversation.
Did I skip and go to
Yeah.
7 instead of 5?
That's okay.
Oh, I'm sorry. I can't see the screen from where I am, so I apologize for that.
No, you're great, Dan.
You're good.
I think they tie together really well.
They do.
I mean, I think a lot of them, there's a lot of
Right.
you know, like recovery, there's a lot of overlap in the concepts and the stigma that's out there, and they are very connected. So Julie, did you want to add anything to the abstinence conversation?
Just the fact that I personally have tried abstinence. I've tried a drink here and there. I've tried harm reduction. I've tried every model there possibly was in my journey. And like I said, medicated assisted treatment has worked best for me. It may not work best for everyone, but that's what's worked best for me. And that's why I'm thankful we're finally coming to the realization that we don't have to be abstinence-based. For so long, there was a stigma against me being a medicated assisted treatment if I go to AA, NA, but now it just seems like everyone is embracing it, and I'm so thankful for that.
That's great. So I'll turn it back to Jeff to cover myth number 6. But first, Jeff, we have a question for you. Talking about Suboxone, does it work for anything other than opioids? Does it work for meth?
Okay, so the evidence base shows us that it is a partial mu receptor agonist for the opiates. All right, as I kind of showed with my cup and my phony baloney glass jug here. But what happens is, as what I'm finding with my wonderful patients, as we are developing a ritual and as we're looking into how clarity of mind and how we're mending our hearts and our bodies and our minds, and as we're mending relationships and families and society outreach, right, that the need to use methamphetamines becomes less and less. And when I work with my patients through guided imagery and motivational interviewing and cognitive behavioral therapies, as we're doing the medication-assisted treatment, I'm finding that they journal more, and it's like, what the heck was I using the meth for? You know, and we're able to bring that to the table and deal with it right then and there. And so that's why people with the polysubstance use, yes, many people do use opiates and methamphetamines and alcohol and the whole milieu, right? And it's all together. We start hearing that, and we are able to then put that behavior to rest easier. And that's how the Suboxone works with that. Vivitrol, I've also seen help many of my patients. And you know, I'm going to quote this wonderful gentleman, came out of jail, had been abstinent in jail for, I think he was telling me he had been completely off anything. He didn't purchase anything in jail for about 67 days, something like that. And so we started talking about, hey, what do you think about Vivitrol? He says, I've heard about it. We tried, so we talked. And he said, no, I'd really like to give that a try. And okay, so we started on Vivitrol with the naloxone tablet first for a week or so, made sure he didn't have any major hepatic or liver problems. And within the first 2 months of getting the shot and whatnot, he comes in, he says, this is what I got going. I'm motivated. I'm going to my counseling groups. I'm going to IOP. I've got a new job. And then a couple of months after that, he goes, hey, Jeff, you told me it was for the opiates, but I was on the bus the other day and an old user friend of mine saw me, came on and kind of, said, did I want to do some clear with him? And he said, he used the F-bomb, so, get the F away from me, right? And he had that strength of purpose and that motivation. And he said, I just didn't want to use. There was a trigger. There was, that was what I had patterned myself before, and I just didn't want to use. So it gave him that dopamine surge within the limbic system that it calmed him down, that he did not need to use, and he was able to balance that out. And then this is the most amazing thing, and I can go on for this for hours, but he comes back a couple months later, goes, Jeff, I used to be a pack and a half a day smoker, and now I'm lucky I smoke 1 or 2 cigarettes a day. What's going on? Why is this working? And then, so that made me really research on how Vivitrol, naloxone, works in the limbic system with the dopamine surge. But we could spend hours on that, and I don't want to bore anybody with that one.
We don't have time to. So let's go into myth number 6.
Okay, so you can never stop taking Suboxone. Who said that, right? We're treating a disease. So if you're a diabetic and you're a really brittle diabetic, and to save your pancreas and your life and all the other systems that make you who you are, you have to be on insulin, metformin, glipizide, glyburide, Januvia, name the vast majority of those diabetic drugs, lisinopril, all that. But then you start getting clarity of thought, you start loving yourself more, and you have support, and you start really watching your diet, and you do your exercise. And by doing that, using the drugs to save you at that moment, but you get better, start healing. And then, oh my gosh, I'm not on insulin. I don't need it because my sugars are leveling out, and I don't need the glipizide or the Januvia, and I'm only on a little tiny bit of metformin, and I'm losing weight and I'm feeling better. That's the same way with this life-saving drug, Suboxone, that eventually, if that's where your control is and that's what you want to feel, that you don't want to be on it at all, let's do it smart. Let's wean, and let's kind of revisit and reevaluate day by day, week by week, how we're doing. So you don't have to be on it the rest of your life, but there are some people that really feel supported and controlled, and they feel safer on Suboxone. Whatever the level is, whatever the dose that they decide, that's their control, and that's what we're here to do to help. So if, it doesn't have to be this myth. You can never stop taking Suboxone. Yeah, you could, but let's do it smart, right? Or let's just stay on it. Whatever works for you to give you your life back, to make you realize that you love yourself enough to take your life back, right? So did that help?
And yeah, Julie, did you want to speak to this slide?
I love what you said, Jeff. It's up to the individual, because I have seen many people who have been on Suboxone or Subutex and have only been on it for a year and then came off it. It just varies on the time in their life, how strong they are with their recovery system and stuff like that. I'm still on it after 8 years. I've winged off many times, but I had some tragedies with my husband and son dying. So I kind of stayed on for that stability that you were talking about and that safety net, just to know that I had that there. But I've seen many people get off of it. So it's just up to the person. So, yeah.
Right,
Great.
Jeff, and I think you said that it's all about choice, right? When you're ready, you're going to do it. It's recovery. It's choice. That's what recovery is. It's all about choice.
Speaking of choice, Dan or Patty or Julie, Jeff, do you want to add anything to myth number 7? Dan covered it before.
Yeah.
While
And I jumped
recovery is a
ahead.
choice, addiction is not a choice. So
Yeah, and this is Patty. This is one of the slides that's probably the most exciting for me. And by exciting, I mean can really fire me up a little bit, because there was a lot of conversation with people in my life where they would say things like, if I loved my kids enough, I would quit. And I got to say that quitting was not dependent on how much I loved my children. There were a lot of things in my life and a lot of trauma that had happened that needed to be dealt with. There was a lot of encouragement I needed, and I really needed to have people in my life that would support me through those choices, that non-linear journey of it going up and down. So I really had to put things into place that worked for me, and that took some time. And it was the connection with people that was the most helpful. I'm not a big fan of tough love, or I think somebody asked a question about how family members can support people. And I think it's important for family members to have boundaries, but at the same time to have some open acceptance when people are trying different paths of recovery and what that might look like. And just understanding addiction isn't a character defect. It's not a moral code, and that stigma it can be internal as much as external. So does anyone else have any thoughts they want to add to that?
I saw that statement, how you can, a family member, support somebody who wants to be on Suboxone. Have an open, honest discussion. Know what you love about that family member and what you want to support with, and then you have to look into your own personhood and say, well, what do I know about Suboxone or the choice that person is doing? Because the other choices before you sure didn't like, right? Whether that led to your family member to jail, or near-death experiences, or danger, right? And so you as a family member loving that person, you don't want to see that again, but maybe you have built up an idea about Suboxone or Vivitrol or some other drug that's a replacement. So, and what you said, Patty, about stigma being internal and external, that's what we have to break today. And I think all of us on this show today really need to see the philosophy behind stigma. And remember, stigma is a characterization. It's a brand. That's what it means in Greek. It's a brand to show somebody was a slave, and that becomes the stigma. So we are all part and parcel of loving one another enough and being compassionate enough to listen and try to work amongst one another. And I tend to go on, so I will mute myself.
no, don't mute yourself, because we're going to go to myth number 8 now. So unmute yourself.
Okay, I'm unmuted now. Yes, myth number 8. I have heard that from many, many patients. Suboxone is harder to quit than heroin. Well, it's dependent on, there's an emotional tie to Suboxone. Once you've been sober and free from the drugs you wanted to get free from, and you feel so good that when the limbic system, remember where craving and where withdrawal stems from, it's that limbic system, which the limbic system really is in charge of 5 things, right? Pain or pleasure, fight or flight, but then memory. And with the change of chemical composition in your brain, your memory becomes faulty. So if you remembered and how hard it was for you to get off heroin, let's say, and then we were able to work together and use the Suboxone to get you off, and now you don't have triggers, and you've learned how to deal with those by your journaling and taking the drug correctly, taking the medication correctly, and it becomes your new ritual of health and well-being and love of oneself and compassion to yourself, and you change, well, then it becomes an emotional thing that it's harder to quit than heroin. And many people try to go cold turkey. Julie, right? You tried to go cold turkey and it was miserable, right? No one wants to go through that stinking withdrawal stuff. But what I love, and I made it a real science for my practice, is let's work together. I want your inclusion and your journaling to tell me how you want to wean, if you truly want to wean and taper down. Okay? Does that help?
Yep.
Great.
All right, let's go on to myth number 9.
Dan, you want to take this one?
Sure, I can do that. So, easiest to spot a person experience substance use disorder out of a crowd. You know, that is such a myth. You know, we don't know the person's story, the person that we think might be high in the crowd. We don't know if they're in harm reduction mode or if they've had some trauma in their life. We just don't know. Sometimes trauma can make you feel like you're high. I mean, people can think that you're high. A funny story, I worked in a grocery store for like 10 years, and I was high pretty much every time I went to work. And when I left, nobody knew it. So it's just, it's funny to me when people say, oh, that person's high because they look the part, right? So there's that stigma again. It's that stigma of because they don't look like I do, or they're experiencing something that I know nothing about, that they're high or they're on drugs or whatever. So it's just almost impossible, I think, for people to 100% say that person is high or that person isn't high. Julie, do you have some more to add to that?
Just the fact that that is so true, because you never know what someone's, dealing with. And the fact is that we shouldn't even judge people like that, because I know in my recovery, I've been judged when I've been sober, completely sober. And they've been like, nope, you're on something, and and I wasn't. And so I may have had a hard day, or I have vertigo, so that could maybe be an issue, that maybe it looks like I'm high or whatever, but it's hurtful, and it makes the person feel less than, and it doesn't help their situation. And so I love the fact that we don't judge here where I work at Pierce Spokane or Pierce Seattle, or Ideal Option. I just think it's important not to do that.
Right.
So,
and again, it's the whole part of recovery, right? It's the stigma, it's the judging, it's not knowing people's stories. I mean, it's just so much. We all, people think that they are so much better than other people. It's that stigma. We have to get rid of the stigma. We need to rip it up, throw it away, burn it, and move on. It's just, until that happens, it's going to continue. So we really try to work through that here. And I know Pierce Spokane, Pierce Seattle, we just, that's a big part of our recovery, is trying to get rid of that shame and the stigma. So
Yeah,
hoorah,
and I think
Dan, hoorah.
yeah, one of, oh, sorry, Jeff, go ahead.
Let's create a movement, man. We're stigma eradication. On my show, Recovery Gone Viral, to help all patients and family members and community members. I'm going to make a shameless plug for my show here on Ideal Option Facebook Live. It's every morning 9 to 10, Monday through Friday. But it really is. Let's create that movement where we're showing compassion to one another, and let's really build this country up, because we all need to be a part of this, of our society, of our community. And with the experiences that I've worked and improved my medical abilities and my healing abilities, it's because of all the patients that trust themselves to me, and we have this open dialogue. It becomes a real therapeutic relationship. And I'd love to see this country have a therapeutic relationship. Okay, enough from me.
Yeah, and
Well,
before we go on to the next slide, I just want to add that I think it is about telling our story. We reduce that stigma as peers by sharing our stories and being willing to talk about all the choices that we made along the way, and really where the hope is in the story. And so that's really, as peers, the way that we try to model our recovery, is to just be transparent and really open about what our experiences were. And I think everyone I know either knows someone in recovery, could be the crowd I hang out with, but either knows somebody in recovery or is in recovery, but somehow it's touched their lives. And I think it's important that we talk about it out loud. So thanks for having us part of this, because that's really important. And then Jeff, you can go on to your next slide.
I'm muting myself. I remembered. All right. So, Suboxone ends up on the street. Well, of course it does. But what we have noticed in my years working with Ideal Option is I have these wonderful stories, and I have these wonderfully heartfelt, sheepish partners that come, the patients that come up to me, Jeff, you know, I took a job out of state, and I wasn't able to get into the clinic, and I relapsed. I'm like, but there's nothing in your urine. There's no meth. There's no heroin. There's no opiates, and there's still a little bit of Suboxone. You relapse? How'd you do that? Well, I bought it off the street. Well, all right. That kind of goes to tell me that you were trying to do the right thing and you were stuck. And okay, we can deal with this. How do we fix this going forward so you don't have to involve yourself with people? Because God forbid you're buying some Suboxone from somebody behind the 7-Eleven in Oshkosh, Nebraska, and the police come and pick you up. That would really, really harm your growth and going where you want to go. So it opens up a discussion that, okay, well, you with what you thought and with what your experience and what you had to do, you did the right thing, although it kind of was a little iffy, right? Okay, big whoop. So what I love about my patients, in the very beginning, they're kind of hesitant or manipulative or whatever the word you want to use. They're not all there. But I got to tell you, after more and more listening and just letting my heart go open, that they end up and go, you know, well, Jeff, I guess you know what you're talking about, and let's talk about this. And then they bring the journal in, and we get to learn about this. So yes, I believe, and somebody correct me if you think I'm wrong, there is an accountability to self. So there is an aspect of kind of tough love. You got to be accountable. You got to look at all the bruises and the damages and the stuff you don't want to look at to understand where you're at and how you want to pattern yourself going forward. So are we going to stop people diverting their Suboxone? Probably not. But with more education and less stigma, less people will be using their Suboxone to make a payment on something, right? That's just me. I'm going to put myself and let everybody.
all right. So myth number 11, is peer coaching and support the same as 12-step sponsor?
Yeah, so I'll just start. I'm going to turn it over to Dan really quick, but I know there's a lot of terms out there: peer support, certified peer counselors, you know, recovery coaches. A lot of those are talking about roles and job descriptions. You know, in the end, peer to peer means someone who has similar lived experience to you. But and Dan's going to talk a little bit about our model at Peer Seattle and Peer Spokane, and be able to kind of explain what we do.
Right. So, thank you, Patty. Yeah, it's you know, peer support for us, you know, is a person who is sitting side by side. There's no power differential. We're going to walk with that person through their journey. We're going to listen. We're going to listen with our heart. We're going to hold that person in absolute regard to whatever they feel is going to work for them. It's a journey that will have many ups and, a few downs, but in the long run, we're going to support that person no matter what the consequences would be. Even if we don't feel it's right, we're going to support them and we're going to let them make their own minds up. Having a sponsor instead of a coach, there's that little bit of a power differential with a sponsor than there is with a coach. A sponsor's going to, have you go through the 12 steps and do the steps, and they're not really, I want to say, vetted. What we do here, in order for you to get a coach is you need to come and, right now it's talking to me, and I listen to their story, and then that's how I connect them with a coach. So I know all the coaches' backstories. So as they're telling me their kind of journey through life, I have all the coaches, I have all their journeys back in my mind. So we really try to hook a coach and a recovery up for people who have the similar lived experience, and it really works. It's a 26 weeks journey for them, so 6 months, and it's really meant to lift them up and then let them go. It's different than a 12-step that way, where you can have them your whole life. It's, we want to lift this person up and see them on their way, and that's kind of what our job is, and it works. I since I've been here in the last 5 years, I have seen so many people, plus myself. I mean, I went through the coach program myself, became a coach, and now that's my program that I'm running. But it works wonders, and it can be hard sometimes, because it's hard to let people make those mistakes, but you have to let them make those mistakes so they can move on. So, Julie, I don't know, do you have anything else you want to say about that?
You covered it. Love it.
Okay.
I think I would just add, I don't think it doesn't need to be just like, different methods work for different people. I don't think it needs to be either or, a peer
Right.
coach or a sponsor. You can have both. You can have peer support, a recovery coach, a peer counselor, and a sponsor, whatever works best for you.
Right.
That's absolutely right. And all those roles can be very important in somebody's journey, that they are able to connect with peers wherever they are in their process. So that was a really good way to put it, Rose. Thank you. You guys are doing a great job. So proud of our team.
Absolutely. This is actually Melody, but that's okay.
Oh, sorry.
That's all right. All right, we're going to go to the last myth, and I think you guys have been answering questions in the chat, but we might have a little bit of time left at the end to answer some questions. But Jeff, you want to briefly talk about myth number 12?
Yes, I've done some work with Ideal Option when we started working with the community outreach and enforcement team of the city of Everett, as well as the Office of Neighborhoods with the Snohomish County law enforcement teams, and developing a changing stigma there in law enforcement was, I thought, that was going to be absolutely detrimental. I thought there was never going to be an end to it, but you know what? I see, because of the evidence, that the people in jail, it used to be, and this was essentially the stigma, the myth, well, if they are vomiting all over themselves and pooping themselves in a jail cell, they're never going to want to do it when they get out, right? No, because so many of my patients got released, and before we started working this really wonderful program, the COET and the Office of Neighborhoods, I had this one guy walk up 6 blocks from the jail to my office, the old office, which was teeny tiny, on a rainy, cold, miserable day, and he was just tearful, and he says, "Oh my God, I'm so glad I'm here at Ideal Option, because I walked by 2 shot houses, I walked by dealers, and if there was going to be one more in my pathway, I was going to use." He said, "It took me everything drag my butt up into this office and let's get started. And it was absolutely endearing and poignant. And so and so that's how we got started. So what would happen is the jails would release somebody and they'd give me a call and we would stay open and they would take that person right from jail to get to our office and get started. And then we started working with drug courts and the jail itself about starting MAT in jail. And there are so many more people working in law enforcement that embrace the aspect of recovery instead of just, well, just go through the withdrawal and you'll be all better, right? So that's, we do know that we have, it's a harm reduction. We've reduced illness, death through opiate withdrawal, through risk of injury, suicide during incarceration, and also if you've been off, of an opiate for 14 days, 32 days, whatever, and you start again, the chances of fatal overdose are so high. So why not just stop that and let's live safely for our individuals who are out there.
Thanks, Jeff. We're running out of time, so I'm just gonna. No, that's great. I just wanted to wrap things up here and just let all the participants know that you can find out more information about Peer Seattle and Peer Spokane at peerseattle.org or at peerspokane.org. You can also find out more information about Ideal Option at idealoption.com. We've recorded this session today, so we'll be sending out the recording to everyone who registered today. It'll also be on our website later, and we'll share it on social media, and I'm sure Peer Seattle and Peer Spokane will as well. I just want to take a minute and thank all the panelists so much, and thank you, Peer Seattle, Peer Spokane, for partnering with Ideal Option to present this webinar today. To all the participants, I really hope that it was helpful for you. And please let us know if you have questions that come up, and we'll do our best to get you an answer. If you want to chat in the chat box with your email address and your question, we can definitely get an answer back to you. Or you can always email me, and I can make sure that the question is answered. And my email is Melody Clark, MELODY CLARK at idealoption.net, and I will do my best to get you an answer. I hope everyone has a really wonderful sunny afternoon wherever you are. Enjoy your day.
Thank you, everybody.
Thank you.
Really appreciate it.
Thanks, Patty.
Thank you.
Thanks, Julie.
I'm honored
Thanks,
to
Dan.
work with you all. Thank you.
Thanks, Jeff. Nice to see you.
Thanks, Jeff.
Bye, guys.
Thank you all.
Bye, Dan. Bye, Julie. Bye, Patty. Bye, Rose. Bye, Melody.
Bye.